Welcome, everyone. Thank you for joining us for the webcast, Reducing Healthcare Barriers in a Diverse Workforce with Peripheral Artery Disease, sponsored by AIMED Alliance. This webcast has been pre-approved for HRCI credit. Please be sure to attend the complete webcast in order to receive your credit. You will receive an email from hr.com within 2 business days. It will include the certification credit information. You may also log into your account and view the credits that you have received. If you have any questions during the webcast, click on Q&A in your webinar controls and type them in. And now it's my pleasure to turn it over to Ashira Ventries.
Good afternoon, everyone. My name is Ashira Ventries, and I'm a staff attorney at AIMED Alliance. AIMED Alliance is a 501c3 nonprofit health policy organization, and our mission is to protect and enhance the rights of healthcare consumers and providers. AIMED Alliance is pleased to host today's webinar on reducing healthcare barriers in a diverse workforce with peripheral artery disease in conjunction with the Partnership to Advance Cardiovascular Health, also known as PATCH. PATCH is a nonprofit coalition of patient and provider organizations working together to educate and advocate for millions of Americans with heart disease. I'm pleased to introduce Jasmine Patel, who is the Director of Policy and Outreach at PATCH and will be moderating today's webinar.
Thanks, Ashira. Thank you all for joining us for this discussion on reducing healthcare barriers in a diverse workforce with PAD. We're excited to bring you all the expertise of clinicians, caregivers, and a benefits professional who have unique perspective on heart disease and how to best treat it. Our program today is about a very important issue that's common yet misdiagnosed: peripheral artery disease. As Ashira said, my name is Jasmine Patel. I'm the Director of Policy and Outreach for the Partnership to Advance Cardiovascular Health, better known as PATCH for short. On this slide, you can see PATCH's mission. As Ashira so kindly stated, we work to advance public policies and practices that accelerate innovation and improve cardiovascular health for heart patients. In practice, we are a patient advocacy organization that works to galvanize dozens of clinician and patient organizations on policy issues that affect access to appropriate cardiovascular care. You can see a number of our partner and ally organizations on the screen here, but if I were to summarize PATCH's goal, it's to support the clinician-patient relationship through policy advocacy. We believe that doctors, nurses, and their patients know each other best, and that appropriate care is the care that is closest to the doctor and patient. We work to empower clinicians and patients to speak up when barriers to appropriate guideline-supported care are impeded by public policy. And in our mind, public policy can mean laws and regulations passed by state and federal governments, but it can also mean policies that are implemented by health plans and their pharmacy benefit managers. So before I go further, I want to thank our speakers for making themselves available to us today. They're all very busy. They're all juggling different balls, and we really appreciate your time here. So we have 3 panelists. The first is Abby Schrader. Abby is a nurse practitioner for Cedar Valley Medical Specialists in Waterloo, Iowa. She's been in active practice for 12 years. She specializes in the treatment of atherosclerotic heart disease, peripheral vascular disease, heart failure, arrhythmias, and risk factor modification. Abby is also a member of the Preventive Cardiovascular Nurses Association. We'll also hear from Kimberly Campbell. Kimberly was born and raised in Greenville, Mississippi, and currently resides in Atlanta, Georgia. Her experience as a nurse helped her attain one of her biggest accomplishments, which is being a caregiver to her mother, Gertrude Campbell, who passed away in 2020. Her mother was diagnosed with chronic limb-threatening ischemia and peripheral artery disease. As Gertrude's primary caregiver, Kimberly used her knowledge and expertise to navigate her mother's various treatments and surgeries. Gertrude was a high-functioning double amputee who became a passionate patient care advocate through the organization Vascular Cures. Kimberly continues to work with Vascular Cures as an advocate and partner in the spirit of carrying on her mother's legacy and mission to improve vascular health for all. And finally, we'll hear from Greg Lawrence. Greg serves as the president of the K Group, a corporate benefits company. The K Group is bringing groundbreaking technological solutions to the group healthcare marketplace to provide significant cost savings to employers and greatly enhanced member experiences for employees. Greg is also an elected official, serving since 2014 as a county commissioner for Williamson County, Tennessee. So in the United States, PAD is already a very serious health concern. It affects millions of Americans. Abby is actually going to give us a breakdown of everything you should know about PAD. But the disease's toll is more importantly expected to rise as our population ages, as obesity rates increase, and as diabetes becomes more common. So it's really important that PAD receives greater public awareness and that people facing PAD have better access to diagnosis and treatment. So Abby, we'll start with you. Tell us a little bit about your practice in Waterloo and tell me what your patient population looks like, and more specifically, the major challenges you face with them today.
Well, I work in a community where it's predominantly elderly. However, I have noticed a trend where we are seeing more patients presenting with peripheral arterial disease as early as in their 40s. And oftentimes by the time they get to me, they already have advanced disease. And we've missed the opportunity to really work on what we call risk factor modification, to get ahead of the disease, if you will. We know that 20 million adults worldwide are affected. And here in the United States, 8.5 million Americans are affected by PAD. PAD is generally a disease process where certain insults affect the inside of an artery. So we talk about, high glucose levels with diabetes and hypertension, high cholesterol levels, nicotine, and then there are other insults, some of which we can't control, like family history. And all of those things that are running around in our bloodstream are beating up at the inside of our arteries, and a cellular process occurs. And as a result of that, we see plaque formation that begins on those vessel walls. It is the same process that leads to coronary artery disease. So I oftentimes will see patients who have both coronary artery disease and peripheral vascular disease. It is the same process that affects our carotid arteries and leads to stroke. So we know that 12 to 14% of the general population is experiencing this, and this increases with age. It's affecting up to 20% of adults over the age of 75. Like I said, I'm seeing younger and younger patients, and I think that is because of our high amounts of Americans who are smoking. Literally in my practice, I think nicotine use and smoking is probably the biggest risk factor that I see with my patients. And oftentimes, by the time they get to me, they've been smoking for years and it's extremely difficult for them to stop. So in my own practice, I would say that generally I do see more men than women. However, we have a tendency to underdiagnose and evaluate women when it comes to peripheral arterial disease. So we do need to get better about that. Women always have very atypical symptoms when it comes to both their heart and their vascular status. So sometimes they don't present with some of those classic symptoms that I'll discuss here momentarily. Do we want to go to the next slide and talk about some of those? Okay, so, did you have a question, Jasmine?
Yeah, no, I was just going to ask, so you were talking about how women are more greatly impacted, but also with PAD, there's a lot of disparities. Disparities is not a new issue.
Right.
Obviously, it's been talked about more when it comes to cardiovascular disease, but give us a little more understanding on who it impacts the most, and specifically what types of demographic groups are more greatly impacted.
So we know, based on multiple studies that have been done in the past, that the Black community and Hispanics are more likely to present with further advanced disease. We've done a poor job at looking at their risk factors and getting ahead and getting that cholesterol under control and talking about smoking cessation. We do not do as great of a job at getting their diabetes under control. So oftentimes those patients will present with more advanced disease, and they are at a higher risk to receive amputations, unfortunately. And we know that they do have higher complication rates post-revascularization and amputation as well. When women do present, they oftentimes also have more advanced disease. by the time that they get to me. So we are also doing a relatively poor job at identifying that early on as well. We are also seeing, in terms of health disparities, where there is not easy access to care in those areas where maybe they are, 90 miles from their nearest primary care office or hospital where they can get this evaluation done. So if there's not easy access to care, then we have a problem. And if there's not good insurance coverage, we see a problem there as well.
Got it. So, we know this, but maybe some of our audience members don't know this, but PAD is oftentimes diagnosed way too late.
Yeah.
The symptoms can be related to so many different things, but, the word peripheral doesn't make people think generally about their heart. And, people don't necessarily associate, oh, I have pain in my foot, and that may be related to my heart. So when it comes to PAD, why is it diagnosed so late? What needs to be done to prevent worsening outcomes? And my third question is, what would you say is the largest oversight in diagnosing PAD? So we have a slide here. You can talk about screening and treatments and the whole journey to making sure you're preventing an unfortunate amputation.
Yes. Well, interesting enough, sometimes when I get referrals for PAD patients, it's because it was found coincidentally. Yeah. Like they had lung cancer screening and there was maybe a thoracic aneurysm that they noticed, or they were having abdominal pain and got a CT, and suddenly we noticed that there was an abdominal aortic aneurysm there. Maybe they presented to the emergency room with like transient ischemic attack symptoms, and we go on to find that they have carotid disease. So sometimes it is coincidentally caught. Generally, patients, when we talk about lower extremity peripheral arterial disease, that can include both that plaque buildup that occurs in the arteries, and it can also include aneurysms. You can get an aneurysm literally in any artery of your body. Patients will oftentimes experience leg fatigue or muscle achiness that occurs with walking, and generally it will improve or resolve with rest. However, some people have chronic back issues and they will attribute their symptoms to their chronic back issues, or they'll think it's maybe sciatic nerve pain. Sometimes we get patients who present to us with a non-healing wound, and they've been sent from the wound clinic because the wound clinic needs to know, is there a problem with their vasculature in terms of why this wound isn't healing. So when patients come to me, I oftentimes will start, if it's a leg symptoms, with an ankle brachial index. And this is very basic screening. What we do with this is we take the lower extremity systolic pressure over the highest brachial pressure, or that highest arm pressure, and it gives us a ratio. And that number can give us an idea if there's maybe mild peripheral arterial disease, or if there's more moderate disease, or if there's severe disease. And it can also tell us if maybe there's just very distal small vessel disease. So once I gather that information, that helps guide my further workup and evaluation. If an ABI is suggesting severe or even moderate disease, then I go on to do further testing, maybe a lower extremity arterial duplex study, which is an ultrasound looking at that. Sometimes I'll do an exercise ABI where I repeat that same ratio number after they've walked on a treadmill. Then I can see what their activity tolerance is. With carotid screening, it's very simple. It's very basic. It's a simple ultrasound of those neck arteries to give us an indication how much plaque buildup is there. And that abdominal aortic aneurysm screening, same, very basic ultrasound, just to look if there's any potential presence of aneurysm there. When we start looking at treatments, generally with peripheral arterial disease of the lower extremity, we really like to focus on exercise therapy. This is something that has been highly underutilized here in the United States. Patients want a quick fix oftentimes, but that doesn't exist. The more walking you do, the more likely you're able to create a collateral flow, meaning you can grow your own natural bypasses to get around some of these blockages. There are really important medications that we do need to use. Number one, aspirin or some form of antiplatelet medication. So aspirin, even just an 81 milligram daily, is extremely important. Sometimes I will use clopidogrel, or the other name is Plavix. And xylostatisol is a generic medication that has been on the market a long time, and it also helps control symptoms of PAD, or we call it claudication, that leg pain and discomfort. It's extremely important that patients who are diagnosed with PAD get started on a statin. For those patients who seem to be statin intolerant, we use Zetia, or even now newer treatment options include PCSK9 inhibitors, and those are more expensive. So sometimes, we start with the more basic stuff and we have to work our way up. The guidelines do recommend we get patients on the highest tolerable statin dose. And once we have them on the appropriate medical therapy, and we've really done what we can for PAD rehab, which can be done in a controlled environment under nursing staff. In my facility, we use our cardiac rehab staff that does our PAD therapy. If we are finding that patients are failing medical therapy, then you can justify revascularization, which could include a balloon to open up a blockage, or a stent, or even bypass surgery sometimes. We really need to do better here in the United States, though, to really optimize that medical therapy. We've not done a great job. And again, oftentimes by the time patients get to me, we've let that go too long. In my experience, patients do respond very well to exercise therapy. They do have improvement in their ABI numbers, as well as their symptoms and their ability to walk further distances. Once we start revascularization, it seems like a whirlwind where eventually they're going to need something else again. And it keeps adding up, and it keeps becoming a bigger thing for them. So we really have to get ahead of the game here. That's the most important thing. So screening can help us identify those patients who we need to be more proactive with and get on top of the game with their medical therapy.
Yeah. And obviously, when you're at the point of revascularization, you're trying to prevent an amputation. But as you said, once you need a revascularization, treatment just becomes more complex. So the goal is to prevent even the need for a revascularization procedure, right? So in the case we're screening, Abby, who exactly should be screened for PAD?
So I think we have to look at our risk factor profile. So patients who are diabetics definitely need to be screened. Patients with hypertension or high cholesterol, I think it is also important to be aware and to start screening them, and at least to be knowledgeable if they're having any symptoms. Abdominal aortic aneurysm, if there's a first degree relative, so that's mom, dad, brother, sister, who have been diagnosed with an abdominal aortic aneurysm, those patients should be screened. The guidelines do suggest that we screen men 65 to 75 who are smokers. But again, we have to look at each individual in a unique way. What are their risk factors? Do they have a 58-year-old brother who just had a ruptured abdominal aortic aneurysm? We have to be better about paying attention to that. So I think, we look at our risk factors. People who do have risk factors, it's a cheap and easy way to do an ABI, to get a carotid screen, to get an abdominal aortic aneurysm screen. These are very cheap and easy tests to do. In my office, you can get screened. So we do have some very asymptomatic patients. They just want to know. Generally, we do $25 per test, or we'll do like $60 for all three. Lifeline Screening does a really beautiful job at checking both an ABI, abdominal aortic aneurysm, carotid screening, and they also check for atrial fibrillation, which is a heart arrhythmia that can increase your risk of stroke. And I believe they do bone density screening as well. So you can really get a lot for your money there.
Got it. And how often should Lifeline screening take place? Abby?
You know what, I would say, so with Medicare in particular, you know, they do cover a one-time abdominal aortic aneurysm screening. For ABIs, it's easy. Every couple years for patients who are smokers, who have high cholesterol or hypertension or diabetics, I think it's worth doing that every couple years. It's cheap, it's easy, it keeps us ahead of the game. Carotid screening, you know, every couple of years as well. If we do see any disease there, then they fall out of the screening category, and then they come to a specialist like me where I will follow it yearly. So once we see disease, that takes us out of the screening category, and we're more proactive about really closely following that disease process.
Yeah, right. So the goal is to encourage them to screen, but also give them the ability to screen through access.
Yeah. Yes. And just to really identify who needs better medical therapy here.
Yeah.
Who do we need to focus on and get their other risk factors under better control?
Okay, great. Thank you, Abby, for that breakdown of PAD. We'll come back to you in a minute. Kim, so tell us a little bit about yourself. You are a caregiver, but also you're a nurse, a critical care nurse. So talk to us about you.
Hi, everybody. I'm Kimberly Campbell. I've been a nurse for 18 years. Now, most of my background was med-surg tele and med-surg ortho, but in 2012, I did work in the ICU, and I stayed there from 2012 to 2016. And there I learned about pulling sheaths and a lot of reasoning why we do certain things as nurses. I learned more about the body systems. So it kind of advanced my knowledge of nursing while I was there. And what I learned there helped me, not knowing that it was going to help me when my mother got sick. So that's kind of where I was with the critical care aspect of nursing.
Right. So as we talked about earlier, your mom had PAD, was a double amputee, but I understand her journey to kind of navigating her PAD diagnosis wasn't so straightforward. So tell us a little bit about your mother and her situation living and navigating through PAD.
Well, my mother was Gertrude Campbell. She was a very charismatic person, strong-willed, and she was like the first Black female to work at the post office in Greenville, Mississippi. She was the first Black postmaster in Starkville, Mississippi. So she set a lot of milestones. But and then in her 70s, after she had retired from the post office, she worked for a physical therapist. And when she became a diabetic in her 40s. And then in her 60s, she kind of had wounds that healed on and off. And she began going to the wound healing center. And in her 70s, she got a wound that wasn't healing. And that's when hyperbarics and grafts and all that was introduced. And simultaneously, while I was starting critical care, that's when her problems started to begin like more aggressively. And in 2014, she got a wound. She couldn't hardly walk. She began to get leg pain. I took her to the ER. They unwrapped her leg and there was no skin on her calf. And I was devastated. And there began her admission, Dopplers and all that. But all through the years, my mom had been going back and forth to the wound healing center, getting her leg wrapped and getting different treatments. But nobody had introduced any cardiology. There was no cardiologist on board, just wound care and infection control. So no Dopplers were ever done. And by the time they figured out that she had CLTI, it was too late. And they tried different interventions to save her left leg, but they were unsuccessful.
Okay. And at what point did your mom start dealing with symptoms? How old was she?
So really in her 60s, she had some wounds that were slow healing.
Okay.
at 70, that was like in 2012, she got wounds. So she was working and driving herself to the wound healing center and getting leg wraps and different treatments and working. So that's when she began to get the symptoms of PAD.
Yeah.
But when it got really bad, when it was too late, it was in 2014. I think she was about 72.
Got it.
And-
Okay.
Right.
And so how did your mother's diagnosis impact you, Kim? I know you had to deal with taking care of her, and it wasn't the best situation for you, especially in your work environment.
Well, my mom's PAD affected me mentally, physically, and career-wise, because like I said, I had just went into critical care, and I kind of wanted to do that to advance my career and to know more about why I was doing things. But when my mom got sick, I immediately had to take off FMLA. And I don't know, in the hospital, like as an ICU nurse, you can go to different floors and work, but ICU nurses pretty much cover each other. So me taking off was a hit to my floor. But I took off several weeks and with my mother, and I was right there by her side through different procedures. And actually, she was in the hospital I worked at, and the doctors knew me. So she would have like arteriograms with stents, and they would leave me in there to watch her leg to make sure it wasn't any bleeding, because they had us like on the med-surg floor. But this is my mom, but I'm a critical care nurse at her bedside. And so through all the pain and all the procedures, I was right there at her bedside at my job, at the hospital I worked at. And I don't even know if they knew what I don't know if the ICU nurses understood what I was dealing with, because I wasn't, back there with them. And I took off several weeks. And then when I did go back to work, they weren't too happy with me, and I wasn't able to stay in the ICU. I ended up doing nursing home because the schedule was easier for me to help my mom, and it wasn't as stressful as being back in the ICU. So it really like made me change my career path in a sense, because I had to factor in how to help my mom, and I was going to do that because I had a great mom. So.
Right. Wow. I'm sorry about your mom's passing, Kim. That's really tough to deal with. But you as a critical care nurse, I'm sure throughout this process, you had a learning curve with PAD as well, right? So I'm sure you having to deal with your mom's diagnosis and journey has made you much more aware of the condition that maybe you had not been aware of in the past. Is that correct?
It has.
Yeah.
And it helped me throughout her diagnosis too, and the things that she had to go through. Do you mind if I tell one story about what happened with her?
Of course, yes.
Well, my mom lost her first leg in 2015, and that was kind of our first experience with PAD. But when she found out that her leg was occluded, she was occluded bilaterally, femoral all the way down to like tibia on both sides, and they were able to open up both femoral arteries, but not from the knee down on the left leg. So, well, below the knee on the left leg. So that's when she lost her first leg. But on her right foot, basically, she had a necrotic toe. So with the necrotic toe, and I think mentally she wasn't able, like they didn't go right in and do like a double amputation. They kind of watched that right leg. And so wound care, it was weekly wound care and stuff like that. So immediately, I was involved with that. So we were back and forth with weekly wound care trips and stuff to watch the toe and monitor that. And finally I met while I was working in the ICU, a doctor named Feluso Facaretti came to work with us. And he was basically big on PAD and preventing amputations. And I was telling him about my mom. He gave me his card. One day we were at the hospital to get some checkups and stuff for my mom. And he met her and he told her to come see him. And he said he was going to try to open up her leg on the left side. And also she was having some problems with her stump. But when we did go to see him, he was working in a town like 30 minutes from where we lived in Greenville. And he was doing procedures at the hospital, but he was putting his patients on the postpartum floor. And so I was working in the ICU, so I had pulled sheaths, and I had worked with him and other doctors that did arteriograms. But after she got her after she got her right leg done, she ended up with a hematoma. So she came back to the room with what they call a film stop, which is an apparatus that was holding the hematoma. And after a while, the nurse takes it off and then they monitor her. So like at midnight, which was supposed to be like a few hours of procedure and go home, it turned into like hours and hours. And then midnight, the nurse was like, "Oh, you can go home." And I was saying, no, she can't go home, because she felt faint and I still saw a hematoma. But like my eye was trained to see it, but maybe something that, she's a postpartum nurse that she wasn't trained to see. So I really pressed the issue of her calling the doctor, and finally she did. And I was telling her my mom probably needed fluids and labs. The doctor came and he pushed the hematoma out and she had to stay. The next day she needed blood, but it was just, I don't know if it's because of the area. Greenville is in the Mississippi Delta. It's a rural area. So we have had, it has some good doctors, but not a lot of specialty doctors were coming to the area. And so some of the, like Dr. Facaretti introduced some specialties, maybe that some of the other doctors weren't doing. So I had to really advocate and fight for my mom with this nurse who wanted to send her home because she could have sent her home and she bled out,
Yeah. Wow. Well, your mom is really lucky to have had you, Kim. But Abby, so when we're talking about amputations, once somebody gets an amputation, it's a very complex situation thereafter. And unfortunately, statistics are is that they have a higher chance of mortality even within the year they've had their amputation. So can you like talk to us about what happens once somebody does have an amputation? Because it relates back to the importance of preventing it in the first place.
So I have one patient in particular who has advanced peripheral vascular disease. And since he's became a patient of mine, he's had double below the knee amputation. And I can tell you, it didn't start with a below the knee amputation. It started with a toe, and then it went to a foot. And then, he continued to have wound healing issues. Once they do an amputation, there is a wound there that still needs to heal. If you don't have enough adequate blood flow there, that wound won't heal. I recall it taking him at least 6 months for stump healing. And after his stumps were finally healed, prosthetic fitting and months of physical therapy to learn how to walk in his prosthetics. His wife was so lucky. He was so lucky. His wife was a retired nurse practitioner. So he had, like Kim, he had somebody on his side who had knowledge, but a lot of patients don't, and they do all of this blindly. So it's not a quick recovery from an amputation. It takes months, if not years. And even then, they still have peripheral arterial disease. You have to ensure that that arterial flow going to that stump is staying open, and that they're not, a prosthetic, it can rub just right on a stump and you can have a wound again, and you're right back to square one.
Yeah.
So they snowball effect.
Right. So Greg, I think you have a lot of knowledge you can share with us, but first, after hearing from Abby and Kim, What are your perceptions of PAD?
Yeah, well, thanks for having me today, Jasmine. It's an honor to be here. So just listening to Abby and Kim talk, I think from Abby, from her comments, that most of the people on the call today probably weren't as aware of PAD as they are now, and at least they didn't know the scope of it, and how prevalent it is. And the most impressive comment that I heard from Abby was, she says, by the time that most people know they have it, it's already advanced. So that underscores the importance of getting the screenings that she talked about in the early stages, because if you wait till you know you have it, it's already too late. It's going to be much more difficult and expensive to treat. Kim's story is heartbreaking. It's unfortunate that her employer wasn't more sympathetic to her position. I think everyone in the audience today needs to be aware that at some point, most of us are probably going to be thrust into that caregiving role. And it's not a role that you choose. I'm in that role right now. I got up at 4 o'clock this morning because the nursing home where my mother lives, they called me and said she had fallen and hit her head. So I had to get up and take her to the emergency room. And I spent 4 hours in the emergency room with my mother this morning. And that was how my day started. And that's the kind of stuff that comes up when you're a caregiver. It's very emotionally, physically, mentally, and emotionally draining. And as an employer, I think it's very important for you to be aware of some of your employees that may be in those roles, and to come alongside them and be a helper to them, an advocate for them, and help them, give them the tools to be good caregivers, and instead of being an impediment to them. So I think that's an important takeaway that I got from Kim's presentation today.
Sure. And there's kind of two layers to this. One is making sure that those who need access to screening and adequate treatment have it, but are aware of it. But more, especially encouraged to utilize these preventive services once they have it. But then in Kim's case, as you were saying, also ensuring that people who need to care for a loved one navigating a debilitating disease is able to do so. And ultimately, it comes down to keeping good employees in the workforce. So how, Greg, in your mind, should benefits plans be structured to ensure they meet the needs of their employees?
Yeah, and some of the audience members may be wondering, does our health plan cover this for our employees? And the answer is most likely it doesn't. Most health plans don't cover those basic screenings that Abby recommended today. But here's what you must probably are aware of: if your employer is self-funded, which most of the HR professionals on the call today probably work for employers that are self-funded, you probably realize you're in complete control of your summary plan description. So I would recommend that you go into your summary plan description and look for under your coverages and see if your plan covers this. But if it doesn't, you can add language to your summary plan description that would cover the test that Kim recommends. And here's some sample verbiage that we suggest you could just pop into your summary plan description. You can contact your TPA. They will help you with adding this to your summary plan description. And that way your employees can have access to the screenings. I think it's important to add it to the wellness benefit so that they get it at 100%. And the tests aren't that expensive. In most areas of the country, it's about $100 for these tests. So we're not talking about, or less for a what is it for a brachial index, Abby, in your practice?
How much does it cost? Or
Yeah.
So just a basic ABI for screening purposes, we generally charge $25. Now, if a patient comes in with symptoms, then generally I can order an ABI and insurance will cover some portion of that test.
Right. But if it's just a wellness screening and you want to do a wellness screening, it's generally not covered, but you can change that.
Right.
You can, it's an easy fix. You can put some verbiage like this in your SPD so that your health plan will cover this. And because if it's a free benefit, your employees are going to be more likely to use it.
So Greg, you talked about some wellness programs. Just what are some sample wellness programs when it comes to kind of thinking about the person as a whole person and preventing just general cardiovascular disease? Are there some programs that you have experience with or you can recommend?
For cardiovascular disease?
Yeah.
Well, there's we're going to recommend some organizations at the end here that have some information on that. But in general, I think it's important for everybody on the call to understand that 80% of your claims are coming from 20% of your employees who have chronic disease. So if you go back in and you review your claims data and you go in there and you find people, you will find that most likely, the vast majority of your claims are coming from people who have chronic diseases. So that's why we recommend today that you take some steps to put some preventive care in your plan if you don't have it. Every insurance company in America understands this. They are all trying right now to figure out ways to change their health plans to encourage their subscribers to focus more on wellness. That's the key. If you're going to affect your claims, then obviously you've got to get at what's the big drivers of the cost. And the big drivers are people who have heart disease, or other types of chronic diseases. Of course, diabetes is another big one. Diabetes can lead to heart disease. So it's important that you get to those people, because there's people that work for you right now who are going to be in that category soon, and they don't even know it. So that's why it's important that I think you have a very strong focus on preventive care in your company to promote, because if you're self-funded, you're just like an insurance company. You are the insurance company. Your employer is paying the claims.
Yeah, that's good perspective. And actually it dovetails well into my next question for Abby. So Abby, talk to us about some of the economic burdens of cardiovascular disease and PAD. And I know you have a slide here to kind of break it down.
Yeah. So the cost implications for PAD are impressive in a bad way. Cardiovascular disease in general will exceed $1 trillion by the year 2035. And individuals living with lower extremity PAD have a combined annual cost exceeding $21 billion US. So it is an extremely expensive disease to treat late in the game. Prevention is key here. It's going to be much cheaper to prevent disease than to treat disease. So individuals with PAD have higher health-related expenditures and out-of-pocket expenses compared to other US adults. This can include lost wages, care by family members, lost opportunity costs, increased burden carried by patients and PAD. So we're looking at increased rates of being absent from work impairment. Sometimes these patients need restrictions on what they're allowed to do. Physician visits, emergency room visits, hospitalizations. And not only that, but somebody who has advanced peripheral arterial disease has a decreased quality of life, both mentally and physically, in terms of what they can do. So we know that the total average annual expenditure per individual for patients with PAD was $11,553 compared to just $4,219 for those without.
Yeah, I mean, that's amazing. And even when it comes to just, some people have the ability to afford out-of-pocket costs, right? But then there's others who just don't. And so when it comes to paying for a screening, if their insurance doesn't cover it versus buying
Yeah.
food, for example, I mean, it's something to really consider, because obviously they're going to care for their needs of their family and their children, what have you, and they might avoid actually paying for these screening costs because they don't realize that it's important to just detect things, or maybe not detect things because you're continuing with screening rather than waiting until it's too late and you have these exorbitant amounts of emergency room costs, physician visits, as you said, hospitalization. So, I mean, those numbers are really, they're tremendous.
And I think about, with Kim's mom, all of
Yeah.
those visits to wound clinic and, the supplies that they need to do their job and medications that we use, for patients who have really terrible cholesterol, these PCSK9 inhibitors that are out on the market that work wonders, they are very costly drugs. So it all adds up.
Yeah. Yeah. And, Kim, Abby was talking about quality of life. So talk to us about your mother, before she was dealing with PAD and then kind of going through it and then going through the worst aspects of it before and after, and how that even affected her mental state. I think it's important to touch on that.
Well, before my mother dealt with PAD, she was very active in the community and with her job. I mean, she was a retired postmaster, so she was always working. Then she became a office manager at a physical therapy office, and she also helped on the floor in the physical therapy office. So she was very smart, retired federal employee. She cooked, she went to the grocery store and everything. And so when she got PAD, and it affected her legs, and then she could no longer drive and walk. It was hard on her. I mean, initially, the knowing that she was gonna lose her limb took a mental toll on her. And I saw that was the first time I ever saw a depression over my mom, and I had to really advocate for medicine and appetite medicine and stuff. It really affected her mentally. But because I dealt with patients, I just tried to be very positive and reassure her that, she could still live, and because of her attitude, she was able to, still have a good quality of life. She went to Congress and spoke to Congress about PAD after she lost both of her legs. But so with legs, she could do a lot. And without legs, she was still just an active and dynamic kind of woman.
Yeah, absolutely. Greg, there's a question that came in. Maybe you can't fully quantify this because it requires data, but maybe you can shed light on it. So if you can help prevent or detect chronic disease earlier through tests, what are the long-term cost savings here?
Well, Abby just gave you the numbers. It's $11,553 for an average cost per year for someone who has advanced PAD. So if you're a self-funded employer, that's going directly to your employer's bottom line. So the cost of those tests, that's really high ROI. If you can pay for those tests and get the employees in there to catch the PAD early, then obviously the savings would be substantial for your employer.
Yeah. I think we need to kind of think about prevention as an investment in health. As you said, unfortunately, the way our healthcare system works now, it's almost like we're constantly putting a Band-Aid on things. And we all know that Band-Aids only work for so long.
Yeah.
So, we have 2 more minutes here, and then we'll open it up for some Q&A. So for the people who are on the phone, trying to put all this information into practice, I'll ask each of you, Abby, Greg, and Kim, what would be your takeaways for them? So we can start with Abby, and then we'll move on to Kim and then Greg.
I think takeaways are promoting risk factor modification in your employees, encouraging them to quit smoking if they're smokers, offer some incentive there, offer lipid or cholesterol screening and blood pressure checks. And for those patients who you see that they meet those risk factors, really encourage and push them to have screening done to get ahead of the game. Because again, they're in the long run, preventative care is so much better than tertiary care.
Absolutely. Kim, any last minute thoughts?
Yes, I'm hoping by doing webinars like this and telling my story that this can make like HR managers and everyone start thinking about PAD like they would think about cancer or MI. You know, we know that those are core measures. And I always felt like when my mom was sick, if I told them, oh, my mom has cancer, they would have been more empathetic about what I was going through. But PAD can be just as devastating as any other diagnosis with a poor prognosis. So I'm hoping that by telling my story and working with organizations like Vascular Cures and stuff, it can make people aware and jobs aware that PAD is very serious.
Yeah, and there was some comments that came in from people watching how your story helped open up their eyes to PAD. So I think it's really important to hear kind of a firsthand experience. It just sheds even more light into the situation of what it's like from the lived experience. So thanks for sharing your story, Kim.
Thank you.
Greg.
Yeah, so as we said, you know, make sure you got your benefits structured so that your employees can have access to the preventive care and treatments that we've recommended here. And then communicate those. I mean, communication to the employees, it doesn't do you a lot of good to put the benefits in there if the employees don't know they're there. So then you need to communicate to the employees that these benefits are available and why, the importance of why they need to get the screenings, and maybe even partner with the local clinic like Abby works for, and help them find a coach. You know, the lifestyle changes are huge here. That's hard to do. It's hard for anybody to change their lifestyle. A lot of times you need a coach like Abby to help you say, yeah, you really need to quit smoking. Or down here in the South, we've got what's called meat and threes, where we go in and we can get the chicken fried steak with gravy and mashed potatoes. So, you know, we probably need somebody like Abby to say, you really need to stop eating that or you're going to get worse. And then here's some organizations that we talked about earlier that you can help your employees to connect with. If your employees say, hey, I think I may have symptoms, or my mom or dad may have symptoms. What can I do? Where can I get more information? So here's a list of some organizations that you can contact that would have some information for you there.
Yeah, and I want to kind of touch on your last note, Greg. It's really important for people to have a sense of community when they're dealing with something, and be able to talk to other people who understand what they're going through, but also being connected to advocacy organizations and patient organizations especially is so important when it comes to empowering that person. I mean, Kim, can you talk about, for example, you know, when you were going through this with your mother, Vascular Cures was there with you, and you are still obviously in touch with them quite often. You speak on behalf of them. Vascular Cures actually connected you with us, but talk about how during the later stages of your mom's journey, how Vascular Cures helped her and helped you.
Vascular Cures have been great. Lisa that works with Vascular Cures was really a friend of my mom. We went to San Francisco for an event, and my mom got the Ron Stoney Award. And she was able to tell her story and just to make an impact and tell people what she had been through to prevent them from having to go through it. And after my mom, Vascular Cures stayed in touch with her, and after she passed, you know, they reached out to me and allowed me to be a part of their organization as a patient advocate, to tell my story, and hopefully, you know, it connect me with other people that have PAD, other people that had other patient advocates that had met my mom, and just increase awareness. Sure. And in the community. Yeah. So they've been great.
Absolutely. Thank you. And thanks to Vascular Cares. If anyone needs some more information about PAD, our organization has actually written a really digestible paper talking about addressing unmet needs in PAD. And it really talks about some of the things we covered when it comes to access and lack of diagnosis, but also the needs for people who are maybe living in rural areas and have less access to specialty providers, and kind of what can be done to support the needs of those people. So you can visit our website at advancedcardiohealth.org for more information. I'm trying to see if there's any more questions before I just hand it back to hr.com. Any last minute questions or comments? Okay, well, that's great. Thank you all so very much. I learned a lot. This was extremely insightful, and I hope also people watching this gained a lot of value from this. And as somebody said, open their eyes to PAD and thinking about the needs of people who may be impacted by PAD but have no idea that they are. Thank you so much.
Thank you. This concludes our webcast today. I would like to thank our presenters as well as all of you for joining us. If you joined late and would like to view the webcast again, the recording and slides will be available on hr.com in our archived webcast page. Your HRCI credit will appear in your account within 2 business days, and we also send out an email with the credit information. Please take a few moments and fill out the webcast survey that will open on your screen. Your feedback is very important to us. This concludes our webcast. Enjoy the rest of your day.